Good afternoon. I would like to take this opportunity to thank the local organizing committee for asking me to talk on this talk, which is very important for gynecological practice at our time, talking about the safe gynecological endoscopy during COVID-19. And I will start with a conclusion from my last talk, which went this way. The only constant thing that is certain during this pandemic is that things will continue to change, both in terms of information and experiences. And it's our responsibility to be able to adapt and change accordingly for the benefit of our patients. I have no conflicts of interest to declare. What I'm hoping to talk through is the operating and safe gynecological endoscopy through the peaks and troughs of the pandemic and the new normal, taking into consideration the patient, theatre environment, theatre staff and surgeons, and I'll dwell mostly on laparoscopy as opposed to hysteroscopy, talking a little bit about vaccines and not so much about how we adapt to the variants, as that will be down to the vaccines and normal social distancing. We all sort of recognize this, that the pandemic was declared by WHO in March of 2020. And since then, there have been various lockdowns and opening ups in various societies. The unfortunate thing about the lockdowns is that the lockdowns and the need to flatten the curve and protect health systems has resulted in a great backlog of patients that have been waiting for operation. And the question then is how we then deal with this backlog, and in order to be able to offer safe operating for these patients. We mustn't also forget, as we try to exemplify in this publication of ours, that while women are waiting for these operations, there is a great physical and psychological trauma that might well ensue, which will then be the underbelly of the current pandemic. So the important thing is making sure that we're safe and at the same time mitigating risk to protect the patients, to protect healthcare systems, and also to protect staff. And we'll take on these individual aspects in a little while. When the pandemic first broke, the first question that everybody were asking themselves is laparoscopy safe during the pandemic? Or is it an aerosol generating procedure that we need to protect ourselves against? At the time, there was a lot of social media chit chat and thinking that if the particles were in smoke, would they help in the transmission and therefore put patients at risk, as well as surgeons and theatre staff? And this was based on some information that was actually out there at the time from the Royal College of Surgeons and the American College of Surgeons, which favored laparotomy over laparoscopy as a knee-jerk reaction. Myself and some of our colleagues got together and the BSG subsequently published guidelines, as did many other people. But under the circumstances, when we did go through the literature, we found out that there were more knowns than unknowns in regarding COVID-19, gynecological surgery, and the pandemic. What we did know is that COVID-19 can be transmitted through aerosols and fomites, and that the virus particle was contained in feces, blood, peritoneum, maybe semen and vaginal secretions. That would be important for gynecology. But most of the information that we did have was extrapolated from organisms that we already knew about, things like HPV and HIV. But it must be said that the only recorded transmissions from patients to surgeons has been with HPV, and that in the whole literature culminates in about 4 patients. For the virus to be able to infect surgeons or theatre staff, the virus needed to be present within the particles. There's no data on that yet. The virus will need to be able to be transmitted during the procedure, and it would have to remain virulent. Subsequent to the initial studies, there was this particular study by Mintz and colleagues, and they did a quick narrative review looking at the potential safety of laparoscopy. And in fact, it was found that laparoscopy does have advantages over laparotomy in protecting the gas, allowing us to operate in confined environments. So let's look at the patients for a little while. And what we've got to consider about patients is dividing elective and emergency work. For the elective patient, we have to be able to ascertain that the patient has made a choice to have the operation and that we've offered alternatives that do not convey risk. We've also got to allow the patient time for isolation, which I'll come on to in a little while. We've got to realize what sort of testing we're going to do. For the elective patient, we've got to prioritize them in order to save our healthcare resources. And we've also got to consider patient comorbidities. For the emergency patient, it's important to consider the risk of the ailment the patient presented with and to weigh that up against the patient's COVID status and weigh that up against the risk of the patient having an operation and what the risk may be if we subsequently have to delay that operation. We have shown, particularly in this paper here that was recently published in the BJOG, that even with emergency work, patients are not at increased risk during the pandemic. Even though we did show that patients did show up later for treatment, there was a small increased risk of rupture of ectopic pregnancies where patients presented with increased hemoperitoneum, but they were equally able to access minimal access laparoscopy, and that registrars were still able to operate on these patients with no added complication or risk. So looking at the risk, what is the risk of operating on patients during COVID times? Most of the information that we have available comes from the COVID surge group, and the mortality was thought at the time to be about 24%, and pulmonary complications in the region of 51%. But we have to take into consideration that this was a worldwide initial study, and the risks may well not be that much. If you then delve down into the patients that were particularly at risk, they were the older male who was having a cancer surgery. The elective procedures were a little bit more protective than emergencies, and major procedures conveyed more risk than minors. If you then look at the gynecology subset, the risk was about just under 5%. But again, looking at the older patient with a greater ASA score. It's important to ascertain the tests, what tests we do for patients. The best test, of course, will be the PCR. The lateral flow would be for the emergency patient in whom we cannot wait because of deterioration. Another COVID research paper has shown how important it is that the patients have a PCR swab at least 3 days before their procedure. And taking into consideration the patient will then need to have another swab on the day because of the interpretation of the initial test, and we'll come on to that if I can in a little while. The patient also needs to be tested sequentially depending on how long they stay in hospital. So a good paper to read for the interpretation of a test is this BMJ paper, and the reliability of the test will depend on the pre-test probability of an illness versus the sensitivity and specificity of the test. The best sort of test according to this model is a positive test where you know that the patient is positive, but with a negative test, the patient may still be incubating the disease. And 24% of patients who have negative tests may well subsequently test positive. So keep that in mind. So we still need to take a history on the day and employ social distancing procedures. For the emergency patient, again, we need to take a history. We need to cohort the patients in what we call an amber zone, and I'll come on to the zones in a little while. For immediate operations, the lateral test may well help with time. If we have time to wait, we do a PCR test. The patient is cohorted again in an amber zone until the COVID test swab results are known. And again, within the amber zone, social distancing and hand washing and all other practices need to be performed. So when we talk about elective patients, we talk about the reintroduction of gynecology once the peak has passed, operating on the number of patients who missed having their operations during COVID times in order to save health services. So for these sort of patients, what we will then need to do is to make sure that we prioritize them so that we can operate on the right patients at the right time, maximizing our resource, and at the same time, allowing our critical care resource to recover. So under those circumstances, immediate operations are P1s, those that can wait for 72 hours would be P2s, and so on and so forth. We also then need to take into consideration the morbidity. In this particular model here, the green patients you could operate on, the ones in the amber zone, you would probably need to do MDTs, and the red ones we can defer until the peak has passed. More modern management would then be waiting until they're vaccinated and swab negative. It's important that the patients know what the added risk is, and therefore there are special consents that we can use to operate on patients during the COVID peaks, as well as during the COVID troughs. From the theatre environment point of view, it's important that we use positive pressure theatres with adequate cycles per second, and that we observe personal protective equipment in terms of face masks, face shields, gloves, aprons, and gowns. Now, in this particular paper, what we tried to do was to summarize what all the learned organizations had put in place, or what advice they had given to ensure that women and staff are safe during the elective admission to gynecological procedures. And this is inclusive of the publication on my right, which was Through Ages, our organization, and published by Alabi et al. And most of these things are similar to the wider literature. Above are the learned societies, and on the left side here are what the advice is. And that advice is summarized in this following slide. The patient we've spoken about, what we also need to do is to make sure that we have the right surgeon, such that the person who is performing the operation knows how the operation is being it needs to be performed in the least time possible, so you expose the patient to minimal risk. We need to make sure that only the people that need to be in theatre are there to minimize exposure. We operate at low pressures at about 12 millimeters. We ensure that we minimize Trendelenburg, make sure that we do not allow the gas to escape into the environment. For this reason, some will advise that you use balloon ports that stop the ports from coming out. We also need to minimize instrument exchange, because that again will allow us to keep the gas within the abdomen. If we need to close ports, 10 millimeter ports, we use direct vision as opposed to having the ports closed by industry provided things like endoclose. Smoke extraction is very important, so we do not let the gas out into the atmosphere. What we would need to do would be to suck up the gas, but in order to prevent the development of hernias, we would then use blunt probes within the ports, retract the ports, and then finish our operation. For things like vaginal hysterectomies, for instance, or laparoscopically assisted vaginal hysterectomies, you decrease the smoke before doing the vaginal bit. As far as filtration goes, the filtration is very important. But as you can see here, the size of the particle of the COVID virus is not much greater than other particles. So therefore, the standard filtration equipment that we use is usually enough. Though there are many on the market, and most of them rely on a 3-valve system or a 3-particulate system to attract or to trap the particles, most of these are equally efficacious. The air seal that some people use, and that is supposed to be so that we can operate at low pressures, but it's expensive and not necessarily essential. This slide I included just to make sure that we are able to educate our staff as to why the changes are and what changes need to be made in relation to COVID, so that they remain aware and everybody remains safe. The other important thing to just touch on is the zoning principle, where patients are supposed to be operated on in green zones. And what it means by green zones is both the theatres, staff, and the patients are potentially COVID-free. As far as isolation goes, this is the latest paper from the COVID Surge group, and what they're trying to illustrate here is that for patients who have isolated and patients who haven't, there is no added risk. So it may well be that over time, depending on our environment, the isolation principle will be removed. As far as operating on COVID patients, or how long will it take for them to recover, the diktat now, following this COVID Surge paper, is that we wait for at least 7 weeks before we operate on patients who have had COVID. If they remain symptomatic, we wait until the symptoms have passed. In terms of vaccination, it would be great to vaccinate all our patients, and maybe once we do vaccinate patients, then how we operate on patients will change. But to summarize, for high-risk patients, in order to prevent one pulmonary incident, you would have to vaccinate 351. For lower-risk patients, that number sort of doubles. So this would probably be the ideal pathway of how to keep patients safe. The patient is prepared. The patient at the moment is isolated. The patient is swabbed according to the principles I spoke about before. The patient is then admitted. History is taken on the day. We adopt our safe practices for our surgery. The patient is then discharged. In order to reduce footfall to the hospital, basically what we would then do would be to arrange a tele-surgery follow-up. So the take-home messages should be, for elective patients, prioritize. The important thing is for emergency patients, we have pathways for COVID positive and COVID negative patients. Whatever we do, we adopt safe surgical techniques. So in conclusion, the only constant with this pandemic is that things will continue to change, both in terms of information and experience. And as I said when we first started, our responsibility as responsible gynecological endoscopists is to adapt with these changes to ensure that our patients and staff and ourselves remain safe. Thank you, and any questions?